Good evening. Our Spring 2005 lecture series continues with tonight's discussion, Bioenergetic Support and ATP Restoration in the Tired Heart. We'll talk about Coenzyme Q, Carnitine, Ribose, Taurine, Arginine, and Policosanol. There are many other nutritional agents that are of value, but we'll run out of time. My name is James Roberts. I'm board certified in internal medicine and cardiology. I've been practicing invasive and clinical cardiology in Northwest Ohio for the past 19 years, and I'm the medical director of comprehensive heart care, the EECP Center of Northwest Ohio, and the Advanced Magnetic Research Institute of Northwest Ohio. The goal of all physicians involved in the care of the patient with cardiovascular disease is the same. The goal of all therapies applied to the patient with cardiovascular disease is the same. I don't care if we're doing open heart surgery or stents or external counterpulsation or MME or chelation therapy or phosphatidylcholine or whether we're giving you coenzyme Q. Our common goal is to increase the content of ATP within the patient's heart cells, the myocytes, and to enhance the ability of those cells to regenerate ATP on their own. ATP is critically important. It's this common goal of all of us involved in the discipline of cardiovascular medicine, because ATP is the only source of energy that can be used to drive forward useful chemical reactions in the heart. It's all we've got. ATP, adenosine triphosphate, is composed of an adenine base. This is the same adenine that's in our DNA and RNA, to which is attached ribose, a 5-carbon sugar, to which is attached 3 phosphate groups. Cleavage of the terminal phosphate to phosphate bond of ATP releases chemical energy that is then used to drive forward useful chemical reactions of the heart. This is the only source of energy to fuel your biochemistry. We need ATP for the heart to contract. We actually need more ATP for the heart and our blood vessels to relax. We need ATP to man the ionic pumps that keep the proper ratio of sodium-potassium across the cell membranes in our heart. We need ATP to pump calcium out of the cell to allow the cell to relax, for the heart to relax, for your blood vessels to relax. We need to use ATP if the heart needs to make new proteins, new structural proteins, or if the heart needs to regenerate ATP, we have to spend ATP. ATP is the only source of energy for the biochemical reactions in our heart. So you think we've had a lot of it, but we really don't. The average heart contains 700 milligrams of ATP. At a heart rate of 60 beats a minute, we're going to utilize 70 milligrams a second. So our 700 milligrams lasts 10 seconds, about 10 heartbeats. We need more than 10 heartbeats a day. We have about 86,000 heartbeats a day. So 6 million milligrams of ATP are utilized. So each molecule of ATP must be recycled or regenerated by the heart 10,000 times. So Mother Nature did not endow us with a large storage capacity for ATP. No, she endowed us with a basically unlimited ability to regenerate our ATP. When it comes to ATP energy, we have just-in-time production and transport. This is sleek and efficient, but it also means that everyone in this room is just 10 seconds away, 10 heartbeats away from total energy failure. That is, if you can't recycle and regenerate your ATP. We need not just enough ATP to fuel the next cycle of cardiac contraction relaxation. We need a high ATP because a high content of ATP within the cell drives forward useful chemical reactions. If the ATP content in the cell begins to fall off, first we have trouble with our calcium pump, so the heart can't relax. The heart will be stiff. Your arterial smooth muscle can't relax. Oh, you'll have high blood pressure. Later on, the sodium-potassium pump, we have trouble there, so we're going to retain sodium and have edema. Finally, when the ATP content is really low, we can't contract. And as the ATP content falls, one by one, cellular functional mechanisms become depressed, eventually leading to the death of the cell. Now, we need to keep this high content of ATP. How are we going to do it? We've only got 10 seconds of ATP in the heart. Phosphocreatinine serves as a reservoir of high-energy phosphoryl bonds. Phosphocreatinine cannot be used to drive forward a useful chemical reaction in the heart, but phosphorylcreatinine can donate a phosphorus group to ADP to make ATP. That gives us 20 seconds of energy reserve. After that, we need to generate new energy. The heart prefers to burn fatty acids and, to a lesser extent, sugar molecules, glucose molecules, in the presence of oxygen in the mitochondria of the cells. That's the furnace of the cell. This is the process of oxidative phosphorylation, our most efficient means of burning calories to regenerate ATP. Now, if we're exercising within our own personal aerobic range, we have a nearly unlimited capability of upregulating ATP recycling to meet our needs. As our heart rate and blood pressure rises with exercise, the rate pressure product, when we have you on a treadmill, every few minutes we increase the speed and the grade, your rate pressure product is rising. We can respond by increasing oxygen utilization to burn sugar and fat, so we can generate energy to match the body's increased needs, to fuel the next heartbeat, while at the same time maintaining a high ATP content in the cell. We need not just enough ATP to meet the increased needs of exercise. We have to meet the increased needs of exercise and maintain a high content of ATP in the cell for reparative processes. Now, what about this guy? He has a high-grade blockage in the circumflex coronary artery. We need oxygen to burn the sugar and fat to regenerate ATP. So when he's exercising and this heart muscle needs more ATP, it doesn't have enough oxygen. You need oxygen to burn sugar and fat. So he will have a deficiency of ATP in this section of the heart. And that will make him short of breath, and it'll make him hurt, and it'll make his stress test abnormal. We put you on the stress test. We see how far you can go. When you get to the point where the cells can't make enough ATP because they don't have a good oxygen supply, we'll see your EKG change. The shorter your exercise duration, the shorter your exercise duration before your EKG becomes abnormal, suggests more advanced cardiovascular disease. That makes sense. The more severe the blockage, the less will be your treadmill time, the shorter is your treadmill time until it's abnormal, because you don't have enough oxygen to burn sugar and fat to make ATP. But your treadmill time is not determined solely by the blockages. The blockages deprive you of oxygen, but you need more than oxygen to make ATP. I'm going to show you several studies where they didn't open up the patient's arteries, but they gave them agents that improved ATP regeneration, such as coenzyme Q, carnitine, and ribose, and they went an extra minute. Your treadmill becomes abnormal not just due to poor blood flow, but due to insufficient ATP production. Oxygen is just one of the things we need. It's an important thing, but it's not the only thing we need to make ATP. And we got to keep a high level of ATP because, if we wait for the heart pump function to fall, we've waited way too long. So how do we deal with this problem? All of my patients suffer from ATP deficiency. Either they've got blocked arteries or their heart's under strain. We biopsy their heart, they're going to be low in ATP. Well, how do we deal with this? It's sort of a supply-demand problem, not enough ATP to meet the demands. Well, we can decrease the demand. I can give you drugs that lower your heart rate and blood pressure, lower the contractility of the heart, so the heart needs less ATP, they can get by with less. I could tell you not to exercise. That's always a way to deal with your angina. Or I could increase your ability to generate ATP. I can improve the blood supply to the heart. If oxygen deficiency is part of the problem, we'll reoxygenate you with angioplasty or bypass. We can medically open up your arteries. Some of the things we'll talk about: essential phospholipids, heavy metal detoxification. MME, which we'll be talking about in a few weeks, probably works via all these mechanisms. We can improve or restore efficient mitochondrial function with coenzyme Q and carnitine, which we'll talk about tonight, or we can accelerate reconstitution of the adenine nucleotide pool, which we'll do with ribose. Or next week we'll talk about indirectly improving the oxygen supply with ECP. With ECP, we're not operating on you or opening up arteries, we're generating natural bypasses. So if you can't have a surgical bypass or a balloon angioplasty with ECP, we form natural bypasses. That's a means of reoxygenating the oxygen-starved heart muscle. And if oxygen deficiency was the problem keeping you from making ATP, if we reoxygenate you, you can make more ATP, your chest pain will improve, you'll be able to walk farther on the treadmill. But I've been doing external counterpulsation for about 7 years now. There's 1,000 of us in the United States, and I was the 22nd. So I've been doing this a long time. I'm up to about 750 patients. And I've learned that simply reoxygenating the patient is not good enough. The problem is not just oxygen deficiency, it's ATP deficiency. All my patients with chronic coronary disease, their heart muscles will be low in the cofactors and enzymes required to use oxygen to burn the sugar and fat to make ATP. They will be low in coenzyme Q. Their adenine nucleotide pool will be deficient. They'll be low in carnitine. So if I want to get a really good response with external counterpulsation, I will treat my patients for their metabolic dysfunction. I'll use coenzyme Q and carnitine to optimize mitochondrial function. I'll use ribose to speed up reconstitution of the adenine nucleotide pool. Thus, my patients get better quicker, they stay better longer, thus my interest in metabolic cardiology and tonight's talk. And I have some recommendations as to how you can help your body regenerate ATP. We have specific recommendations from the literature for angina, coronary disease, heart failure, cardiomyopathy, improving outcome following bypass, renal insufficiency, claudication, hypertension, cardiac fatigue, minor arrhythmia, post-heart attack status and mortality, and we'll go through all these studies tonight, and you have the numbers in your handout. Coenzyme Q. Has everyone heard of coenzyme Q? In terms of bioenergetic medicine, coenzyme Q is the most widely appreciated by physicians and lay people alike. This is the chemical structure of coenzyme Q. It's a fat-soluble vitamin with a structure similar to that of vitamin K. It stabilizes the cell membranes. It blocks phospholipase enzymes that want to disrupt the cell membrane. It's a great antioxidant. It's our primary metabolic antioxidant. It scavenges free radicals, it inactivates superoxide, it regenerates spent vitamin E. Vitamin E always works better with CoQ than without, and it's good. We want stable cell membranes, we want antioxidant function, but tonight we're going to be talking about coenzyme Q's role in energy generation. It is a primary mitochondrial electron transporter, critical in ATP generation. Now what we're doing when we're burning sugar and fat, we're snipping them down into 2 carbon fragments. Then we will strip an electron from the carbon atom, and we're going to take the energy of that carbon-electron bond from the foods we eat and utilize that to make more ATP. So we're going to convert food energy into useful ATP biochemical energy. So we're going to strip the electrons, and we have to transport them on a system called the electron transport system in the mitochondria, and at 2 steps of electron transport, we have coenzyme Q. Without coenzyme Q, we don't have electron transport. We would be dead in 10 seconds. Without coenzyme Q, we cannot regenerate ATP. Energy-intensive organs use a lot more coenzyme Q than less energy-intensive organs. The heart, the kidney, the liver, and the brain are burning up the most calories. They are the richest in coenzyme Q. However, they will also suffer if you are coenzyme Q deficient because they need the most. But it's not a problem. We can get coenzyme Q from our diet, from kidney, liver, brain, of animals or muscles of animals, and we can make it. I mean, obviously, if it's critical to life, Mother Nature has endowed us with the ability to make it. Now, we snip these carbon and sugar carbon chains down to 2 carbon fragments and we burn them. But if we don't need to burn them, because we've had a big meal, we don't need the calories, we can build with them. These little 2 carbon acetyl groups can be bound together to make things such as cholesterol. And coenzyme Q is formed as an offshoot of the cholesterol generation pathway. So I can make cholesterol all I want, and as long as I can make cholesterol and it's unimpeded, I can make coenzyme Q, which is a good thing. Now, the heart under strain is always low in coenzyme Q. Mother Nature designed us to make enough coenzyme Q to meet the needs of a normal heart. She never anticipated coronary artery disease, heart attacks, high blood pressure, valve disease. The heart under strain is being called upon to burn more sugar and fat than Mother Nature ever planned on. The heart under strain, if you lost 40% of your heart with a heart attack, the rest of the heart's working overtime to pick up the slack, you're not going to have enough coenzyme Q, and you're going to become coenzyme Q deficient. So almost everybody with advanced heart disease is coenzyme Q deficient. Thus, supplementation would make sense, and we have randomized double-blind studies in the cardiology literature showing the value of coenzyme Q in coronary disease, improving outcome following heart attack, following bypass surgery, improving symptoms and mortality in heart failure and cardiomyopathy, improving endothelial function, lowering blood pressure, improving lipids and insulin sensitivity following unstable angina. It's a benefit in end-stage renal disease, migraine headache, Parkinson's disease, and statin myopathy. And we have open studies that were not double-blind showing benefits in diastolic dysfunction, statin diastolic dysfunction, arrhythmia, hypertrophic cardiomyopathy, mitral valve prolapse, and in athletic performance. I'm going to review some of these studies with you. Let's talk about cardiomyopathy and heart failure. What's cardiomyopathy? Think of cardiomyopathy as muscular dystrophy of the heart. The heart muscle is punk. It's not pumping well anymore. Why do we have it? The two leading causes appear to be viral invasion and heavy metal overload. If you're mercury overloaded, you might turn an acute viral infection into a chronic autoimmune attack on the heart. We're seeing more and more cardiomyopathy. The heart is punk. As the cardiomyopathy advances, you may go into heart failure. The heart's not pumping blood forward, so there's poor blood flow to your limbs, so you're tired. Poor blood flow to the kidney, so the kidney responds by retaining sodium. If blood dams up behind the heart, you can be short of breath with exercise. If the blood dams up behind the right heart, you have ankle swelling. Those are the signs of congestive heart failure. So advanced cardiomyopathy will cause heart failure, but any insult to the heart, a large heart attack, uncontrolled high blood pressure, a bad valve, whatever, as the heart begins to fail, you will develop congestive heart failure. How do we rate the severity of congestive heart failure due to cardiomyopathy or any other cause? We look at New York Heart Association functional class and ejection fraction. Now, New York Heart Association class 4 is you're having symptoms at rest, you may need oxygen, you're pretty sick, your 1-year mortality was about 50%. Class 1, you're doing great, you can play tennis. Class 2 and 3 are in between. Ejection fraction is the percentage of blood cells the heart ejects with each beat. If your heart fills with 100 cc's of blood and then it ejects 50 cc's, the ejection fraction is 50%. That's normal. If you've had a massive heart attack, you might eject only 25% of the blood with which the heart fills, so your ejection fraction is 25%. When we're treating you, what we want to do is make your ejection fraction go up and make your functional class go down. And that shows that you're getting better. Now, I mentioned that the heart under strain is low in coenzyme Q, and I can back that up. Here we're going to look at blood coenzyme Q levels. Here we're going to look at heart muscle biopsy coenzyme Q levels. In normal people, or people that have class 1 heart failure, you have a normal level. Class 2 heart failure, class 3 and 4, the blood level of coenzyme Q is falling. The heart muscle level of coenzyme Q is falling. So advanced heart disease, cardiomyopathy, and heart failure is associated with low coenzyme Q in the blood and low coenzyme Q in the heart. A number of studies have been done to see will coenzyme Q supplementation improve outcome in people with heart failure and cardiomyopathy. A few of the studies have not shown a positive effect. And when I read those studies with interest, and in general, those studies used low doses of coenzyme Q, or they treated people who were doing pretty well, who couldn't get a lot better. But the preponderance of studies, when you use an adequate dose of coenzyme Q and you treat really sick people, they've shown a benefit in symptoms, in function, and above all, in mortality. Let's start with coenzyme Q therapy in heart failure back in 1991. 180 patients with class 4 heart failure. You know, their one-year mortality rate then in 1991 was 50%. They had heart failure due to multiple heart attacks, or some people had dilated cardiomyopathy. They took all comers. They had had at least 2 admissions to the hospital. 75% of the subjects were enrolled in the study as they were being discharged from the hospital for a heart failure admit. Their average ejection fraction was 20%, which is really pretty bad. Poor response to standard drug therapy, the best that we had in 1991. Do a baseline assessment, then randomize them to receive usual therapy, same doctors and nurses, plus coenzyme Q 100 milligrams a day, and you follow them for 8 years. And what you find, the usual therapy group, there was no symptomatic benefit, no significant changes in heart rate and ejection fraction amongst the survivors. They also saw that deterioration in the placebo group, in the controls, was associated with a further drop in coenzyme Q. So if your coenzyme Q levels dropped, that means you were headed for trouble. In the CoQ group, their level rose from 0.7 to 2.1 after 60 days. At their one-year check, their heart rate was 9% lower because their heart was functioning better, didn't need to beat so frequently. Their ejection fraction had risen by 76%, from 21 to 38% absolute points. That's pretty darn good. 78% improved in terms of ejection fraction or functional class. 11 of the 90 improved after 2 weeks. The average response time was 40 days. With nutritional medicine, we have to be patient, and we all understand it. Drugs work quick, nutrition works slowly but steadily. Let's look at survival. In the usual therapy group, half died at 1 year, and only 1 patient was alive at 5 years, which is what you would expect. In the CoQ group, 73 survived 1 year, half were still alive at 5 years. 29 were still alive at 8 years. Clear benefit with mortality. This was the first time anyone had ever shown that a physician intervention, something that the doctor prescribed, would improve mortality. That's the very first time. Now, with the drugs we use today, Coreg, the ACE inhibitors, pentoxifylline, spironolactone, they will improve mortality, but up until 5 to 10 years ago, we had nothing in conventional medicine that improved mortality. But for at least 10 years now, we've had coenzyme Q. Some of the patients did better with coenzyme Q than others. They were called responders. Some didn't do as well. Either it was too little too late, or maybe their problem wasn't coenzyme Q responsive. But if you look at the responders, 94% were alive at 1 year, 50 at 5 years, 38% at 8 years. A clear benefit in terms of symptoms and ejection fraction and mortality. Now this was back in 1991 before modern day drug therapy. Modern day drug therapy has improved. So the question is, will coenzyme Q still add? Well, let's look at people in whom modern day drug therapy had not worked. 32 patients with end-stage heart failure on the waiting list for a cardiac transplant. They're all on all the politically correct drugs. You do a baseline assessment, randomize them to receive placebo or coenzyme Q 60 milligrams a day in a gel form. Reevaluate at 3 months, randomized double-blind protocols followed, so there's no bias. The coenzyme Q levels were incredibly low. You ought to be at least 1, but these people had advanced heart failure. They were very, very low. Placebo therapy didn't make the CoQ level go up, but it quadrupled with therapy. It would have been nice to even have it higher, but it did rise with therapy. No effect on ejection fraction, atrial natriuretic factor, which is a marker of pump function, or an inflammatory marker called TNF-alpha. But in terms of symptoms, there was a big improvement. If you have heart failure, you have to get up at night and empty your bladder a lot. We call that nocturia. That progressed with placebo therapy. It improved with CoQ. Fatigue worsened with placebo therapy. It improved with CoQ. Effort, shortness of breath improved a little bit with placebo. It improved a lot more with CoQ. New York Heart Association functional class did not change with placebo. It fell from 3.1 to 2.4 with CoQ, and that's highly significant. How far you could walk in 6 minutes, a measurement meaningful to you and your quality of life, deteriorated with placebo. It improved with CoQ. So in the worst patients in whom standard drug therapy is not working, coenzyme Q does work. Conclusions. CoQ levels are decreased in proportion to the severity of the disease in people with cardiomyopathy and heart failure. Blood levels rise in response to supplementation. Later on, I'll show you that tissue levels rise in response to supplementation. CoQ supplementation above and beyond conventional therapy reduces symptoms, increases ejection fraction, most importantly, prolongs your life. CoQ and angina. Now, what is angina? It's a shutdown in energy metabolism due to oxygen deficiency. A supply-demand mismatch. You have a narrowing, impeding blood and oxygen supply to the heart. Not enough oxygen, you can't make ATP. Actually, it's a supply-demand mismatch for ATP, but in our coronary patients where the major problem is not enough blood and oxygen. CoQ levels are reduced in people with chronic coronary disease. If you have recurrent ischemia, lack of oxygen, that deranges your metabolism and your heart will be low in CoQ. It will be wasted. The people who need CoQ the most have the least. Multiple studies document a benefit with supplementation. Now, first of all, coronary patients are CoQ deficient. I said that, I ought to be able to prove it. Here we're going to take 30 patients with coronary disease, 19 age-matched healthy controls. None are on statins, which waste coenzyme Q. The coenzyme Q levels are 2.5 in the normal healthy people. They're only 0.8 in the coronary patients. If we look at the ratio, we have some coenzyme Q in our LDL as an antioxidant. And the ratio of LDL to CoQ was a lot higher in the patients. They were low in coenzyme Q, so their LDLs were more likely to be oxidized, aggravating the coronary disease, and they had less coenzyme Q in their heart, so you can't regenerate your ATP, and that makes sense. So if the coronary patients are low in CoQ and you need coenzyme Q to make energy, let's supplement and see if their angina gets better. Patients with stable effort angina and a known blockage, you give them 150 milligrams of CoQ a day or placebo over 4 weeks. Placebo therapy did nothing. The blood level rose appropriately with therapy. Treadmill time increased by over a minute, by 18%. Time to ST segment depression increased by almost 2 minutes, 45%. Now, we didn't open up the arteries. We just gave them the cofactors they needed to get the most miles per gallon of the oxygen available, the most molecules of ATP for every molecule of oxygen available. We tuned up the engine. Angina frequency fell from 5.3 to 2.5 episodes every 2 weeks. Nitroglycerin requirement fell from 2.6 to 1.3. They got better by improving their bioenergetic status. Now, in conventional medicine, we think of angina as supply-demand for oxygenated blood. That's the way I was treated, or that's the way I was taught. So does CoQ decrease the oxygen demand like a drug, or does it increase the oxygen supply like angioplasty? Let's look at this. 15 subjects with known coronary disease, all with stable angina, reproducible abnormal exercise EKGs. You do a baseline stress EKG, quantify the degree of ST depression, and then repeat the stress EKG following CoQ, 600 milligrams a day for 4 days, placebo for 4 days, or 90 minutes after a single dose of Pindolol, a beta blocker, or isosorbide nitrate, a long-acting nitroglycerin. And what you find here we're gonna run you on the treadmill, and your blood pressure will rise and fall, your heart rate will rise and fall. Here we have before therapy and the placebo. You see placebo has no effect. Coenzyme Q lowers your blood pressure and heart rate response to exercise only minimally. The drugs lowered a lot. That's how drugs work. They lower your heart rate and blood pressure so you can exercise more, but your heart's not working as hard. You don't need as much blood and oxygen. The drugs work by decreasing demand for ATP. Coenzyme Q really didn't. But the effects were the same. This is cumulative ST segment depression with placebo. Here's CoQ and the drugs. There was no statistically significant difference. So CoQ worked as well as the two drugs. Now, the improvement in your exercise duration correlated with the rise in your coenzyme Q level. People who had low blood CoQ levels that went up a lot, they're the ones that got the better improvement in their treadmill parameters. The more you need CoQ, the better will be your response. That makes sense. Drug therapy works by decreasing oxygen demand. lowering your heart rate and blood pressure. The long-acting nitrates give you some nitric oxide to dilate your arteries, but really they're working by decreasing demand. CoQ lowers your heart rate and blood pressure a little bit, and because it's an antioxidant, it keeps you from degrading your nitric oxide, but really it's working by increasing the efficiency of oxygen utilization. More miles per gallon, more ATP molecules formed for oxygen molecules that can make it through the blocked arteries, improving the efficiency of your metabolic engine. Many other studies have shown same benefits on exercise time, angina frequency, and nitro use. Functional class improves. No major effect on oxygen demand, heart rate, and blood pressure, or blood supply. CoQ works by improving the efficiency of energy metabolism. Thus, it will be additive to any drug therapy that one could think of. CoQ is a benefit in angina. No significant or nuisance side effects. Benefits should be additive to conventional therapy. Statin drugs waste coenzyme Q. Where do we get CoQ? From our diet, from organ meats of animals. That's where they have all their CoQ and their mitochondria. And we tell you not to eat those foods. So we're going to have to rely on our body making it. And it's easy to make coenzyme Q if you can make cholesterol. The statin drugs block this step. They're HMG-CoA reductase inhibitors. So if you take a statin drug, that's going to keep you from making your normal amount of coenzyme of cholesterol. It's going to lower your coenzyme Q production by 50%, period. Is that a problem? Pravachol and Zocor, if you take those, your cholesterol is going to fall by 40%, and so will your coenzyme Q level in healthy volunteers. And the healthy volunteers were making plenty of coenzyme Q. They did not have any side effects. So the FDA cleared these drugs for human use because normal volunteers had no problems with a low CoQ. But if you have heart disease and your CoQ levels are low to begin with, is that going to be an issue or not? You can lower the cholesterol via other means. Questran blocks cholesterol absorption from the gut. It'll lower your cholesterol, but will not affect CoQ, only the statins. Lab rats treated with mevacoristatin, they have lower blood levels and heart CoQ content. If you add a CoQ supplement, you can restore the CoQ levels back to baseline without adversely affecting the cholesterol. So if you take a statin and you want to lower your cholesterol and it lowers your CoQ, you can take CoQ and rectify the situation. You'll still get the benefits of the statin. It'll keep your cholesterol down. Now, rats on a really high cholesterol diet had early cardiac muscle dysfunction because high cholesterol levels like that damage the cell membrane. They gave them CoQ, which protects the cell membrane, heart function normalized. Then they left them on the high cholesterol diet and added Zocor, a statin, and there was aggravation of the pump dysfunction versus high cholesterol level alone. High cholesterol level and Zocor produce reversible cardiac dysfunction even before coronary disease develops in these laboratory animals. What about in humans? Mevacor, a paper came out in the literature. They looked at a bunch of people with borderline hearts. They had advanced cardiomyopathy, ejection fraction 30%. They're walking and talking and doing okay, but they're on the brink. You give them Mevacor, they went into heart failure associated with a drop in CoQ. You stop the Mevacor, they got better. Or if you gave them CoQ, they got better. And it was in the literature. They took a young healthy person, a runner, and did some sophisticated tests of cardiac pump function, put them on Mevacor, repeated the studies, and this healthy runner couldn't perform as well. Why? Ran out of coenzyme Q. Statin drugs cause muscle aching, and they will make one of the markers is your CPK enzyme. So if you're on a statin, your muscles are aching, we may draw a CPK level. Your liver chemistries can become abnormal. You know, muscles and liver need a lot of CoQ. You take it away, you can have dysfunction. So when we put you on a statin, we're always asking you, are you having muscle aching? We're always monitoring your liver chemistries. Now, so I'm going to suggest if you take a statin, take coenzyme Q as well, if there's a patient with pre-existing cardiac dysfunction. I will recommend CoQ if you get muscle aching or your CPK rises. Also, if your liver chemistries rise, we'll give you CoQ, and we'll also give you silimrin and N-acetylcysteine, antioxidants to protect the liver. This way you can take the statin and get the benefits while we're attenuating some of the downsides. Now, let's talk about a formal study of coenzyme Q and statin myopathy. 41 patients with muscle pain attributed to statin therapy. How many of you have had muscle aching due to a statin? A few people. It's very frequent in my practice. A lot of people just can't take statins because of muscle aching. So what we're going to do, we're going to ask them to record the severity of muscle pain on a 10-point scale. We'll measure the CPK, which is released by enzymes. Randomize these symptomatic people to receive vitamin E 400 units a day or CoQ 100 milligrams a day. Reevaluate at 30 days. The CPK did not change and did not correlate with the degree of muscle pain. The CPK really isn't a good marker of statin myopathy. There was no change in LDL cholesterol, and they had left these people on the statin. The pain level actually worsened slightly on vitamin E. Vitamin E wasn't very valuable, but it fell significantly with CoQ. 15% of the patients improved their muscle aching resolved with vitamin E, 86% with coenzyme Q. Coenzyme Q and statin diastolic dysfunction. Now, you need ATP for the heart to contract. You need more energy for the heart to relax. You don't have enough energy, you got a stiff heart. We call this diastolic dysfunction. And it doesn't feel well, and you may become short of breath. 14 asymptomatic patients, they have healthy hearts. They're all set to begin statin therapy because their cholesterol's high. Do a baseline CoQ level, do an echo of the heart, an ultrasound, and look at various measures of diastolic function. Treat them all with Lipitor, 20 milligrams a day. Repeat the echo at 3 to 6 months, and look and see if at least one of these parameters of diastolic function became abnormal while on statin therapy. And if there was some diastolic dysfunction from the statin, you add coenzyme Q, 100 milligrams 3 times a day, keep them on the Lipitor to see if the coenzyme Q would rectify the situation, reevaluate at 3 months. Findings with Lipitor. Now, 71% of these normal healthy people demonstrated a deterioration in at least one echo parameter. So 71% suffered an element of diastolic dysfunction as a direct side effect of the statin therapy. The 4 that did not have diastolic dysfunction, they had greater than average levels of coenzyme Q going into the study. So coenzyme Q was protecting them. Findings with Lipitor and CoQ. On CoQ, 89% had reversal of at least one Lipitor-induced echo abnormality. You want a high E to A ratio. It fell with statin, and you were rescued with CoQ. The E-wave deceleration time, you want a low level. It worsened with statin, and then you were at least partially rescued with CoQ. The isovolumic relaxation time rose with statin, and abnormal, and then there was a rescue. So if you are taking a statin drug, you're probably going to have a little bit of stiffness to your heart. So maybe, I've been recommending if you're going to take a statin, you got a bad heart, you ought to take CoQ. I think I'm going to recommend if anyone takes a statin, they should take CoQ to prevent these problems from occurring. You get the best of the drugs without the downsides. Now, what if you had to pick one or the other, coenzyme Q versus statin? We don't have to do that. Some people are drug-only medicine. Everything else is expensive urine. I also have colleagues that just hate drugs. They get angry with me for using drugs. It's vitamins only. We can get the best of both. But let's say you just had to pick CoQ versus your statin. Which would work best? 25 men with endothelial dysfunction. As we'll discuss at a later lecture, this is the most important determinant of your outcome. If your endothelium is working well, you're going to do great. If it's not working well, you're doomed. Measure at baseline endothelial function, CoQ levels, and then all these subjects receive, in random order, cirvastatin, which is a statin, coenzyme Q, or statin and coenzyme Q. And what you find, after taking a single dose of the statin, your CoQ levels fall by 29%. Flow-mediated vasodilatation, which is 100 times more important than your cholesterol level or your CoQ level. This is the thing, the reality of your cardiovascular system. It was abnormal in those that were going to receive the statin, and it improved on the statin. Statins will improve endothelial function. That's one of the reasons they work. The group assigned to CoQ got just as good a response. So CoQ and statin therapy will seem to help you to the same degree. And if you take both, which is what most of my patients do, you get a similar benefit. So if you had to pick one or the other, it would be a toss-up, but we can just have you take both and get the best of all worlds. CoQ and hypertension. You know, it takes energy for the vascular smooth muscle in the arteries of your body to relax. Not enough energy, they remain constricted, and you have high blood pressure. We're going to take 52 subjects with essential hypertension. 20 had low CoQ levels. That might have been the culprit. Treat them with CoQ 100 milligrams a day plus usual therapy alone. Nothing happened with usual therapy alone. Usual therapy plus CoQ, their systolic fell from 167 to 148. Their diastolic from 97 to 91. This has been repeated, and your exercise, heart rate, and blood pressure response also will be blunted with CoQ. CoQ in athletes. Here they took professional basketball players in Italy, the equivalent like the Italian NBA, at mid-season, and they gave them placebo or CoQ 100 milligrams a day for 40 days. Their CoQ levels rose. Maximal oxygen uptake with exercise, which is your peak aerobic performance, in these professional athletes on CoQ improved by 18%. Their resting ejection fraction improved, their diastolic function improved. Why would an athlete need CoQ? Because they're overdoing it. Mother Nature did not plan on us running up and down the basketball court every night. They've been burning too much sugar and fat. They ran out of CoQ. So most professional athletes are taking Coenzyme Q. The Tour de France cyclists, if you measure their Coenzyme Q levels during the racing season when they're overtaxing themselves, they will be low. During the off-season, their Coenzyme Q levels rise. Long-distance runners, you do stress tests before and after, giving them CoQ 100 milligrams a day for 40 days. Treadmill time increased by 18%, treadmill distance by 13%. So long-distance runners are going to become deficient in the cofactors needed to generate energy in the same way as the coronary patient. They're not over-exercising, they just, they're running out of their coenzyme Q and carnitine, they need more. So heart patients and athletes will benefit from CoQ. Coenzyme Q and cardiac arrhythmia, if you carry out a heart attack in an animal and you pre-treat with coenzyme Q, they're less likely to have arrhythmias. Coenzyme Q decreases your risk of arrhythmia following open heart surgery. Here's a study where they took people with PVCs, extra heartbeats, premature ventricular contractions, due to a number of different cardiac ailments, gave them 150 milligrams of CoQ over 2 to 4 weeks. There was a 50% reduction in PVC frequency and cardiomyopathy, 25% of those with prior heart attack, 32% of those with other cardiac disease, 8% reduction in people with a normal heart. They were probably treating the underlying heart problem as opposed to treating the arrhythmias. But as the heart got stronger, it became more electrically stable, fewer arrhythmias. What about improving outcome after open heart surgery? If I send my patient for open heart, I want to do everything I can to ensure that they're going to have a good response. This study was done in 20 patients at high risk for cardiac surgery. They were all seniors, their ejection fraction was low, they all had low CoQ levels. You do the heart cath 2 weeks before the surgery. And at the time of the heart cath, you randomize them to usual therapy or usual therapy plus CoQ 100 milligrams a day 2 weeks before the procedure, 30 days after the bypass. And you monitor them at various points in their course. The blood coenzyme Q level was low at the time of the heart cath. 2 weeks of placebo therapy, it didn't go up. 2 weeks of CoQ, it went up a lot. This is cardiac cooling when the open heart surgery is occurring. Then they finish the open heart surgery and rewarm the heart. Here we have the surgical recovery room. As we'll discuss later, when you have open heart surgery, your heart is deprived of oxygen for several hours. There's a great deal of free radical stress, and you're going to burn up your coenzyme Q. So with the stress of surgery, you can see the coenzyme Q level falls in both groups. But in the supplemented group, it starts out really high and doesn't fall nearly as much. So at the end of surgery in the surgical recovery room, the supplemented group had CoQ levels 2 to 3 times that of the untreated people. If you measure the tissue coenzyme Q, you didn't do it at baseline at the time of the heart cath, but as you begin the surgery, you can show that 2 weeks of coenzyme Q increased the amount of coenzyme Q in the heart muscle. The coenzyme Q content of the heart muscle fell with the surgical procedure from the free radical stress reperfusion, ischemia reperfusion injury, didn't fall as much if you were supplemented. How much ATP is in your heart? Remember, the whole goal of this is to maintain high levels of ATP in the heart. You can see that just 2 weeks of coenzyme Q increased the ATP content of the heart. They cruise through surgery without degrading ATP. The placebo patients, they're going downhill. They have a successful open heart, but they don't have much ATP afterwards because of the free radical stress. Now, ejection fraction. Now, that's all interesting biochemistry. I think it's fascinating, but you want to know, what's it going to do for my outcome? What about my ejection fraction? The ejection fraction was poor in both groups, like 30 to 32%. 2 weeks of placebo therapy didn't help, but 2 weeks of coenzyme Q increased their EF from 32 to 36%. Now, following surgery, you can see the ejection fraction falls in the placebo therapy. The bypass went well, but because of the stress of the surgery, the free radical stress, their ejection fractions were poor. They're going to struggle in the surgical ICU. Look what happened with the coenzyme Q patients. They respond to reoxygenation like gangbusters. We have a lot of CoQ, we're going to make a lot of ATP, our ejection fraction rises to 42%. Which group's going to do better? In the placebo group, complicated course, all needed considerable and sustained inotropic support, drugs to whip the heart. Intra-aortic balloon pump was needed for severe heart failure in 4. 3 went into kidney failure, needed dialysis. Arrhythmia was frequent, recovery over 15 to 30 days, 2 died of pump failure. In the CoQ group, uncomplicated recovery, arrhythmia infrequent, no balloon pump, no dialysis, no deaths. Which group would you want to be in? I would say CoQ, but you can say, well, it was a small study and it was done in Europeans, so it doesn't count. So here's a study from North America. 122 patients scheduled for bypass. 2 weeks before, randomized to placebo or CoQ 300 milligrams a day. At surgery, you're going to remove heart muscle and look at various metabolic parameters. And what you find in the supplemented patients, there's more coenzyme Q in their myocardium, and there's more in the mitochondria. That's really where it's working. So you take it, it gets into the heart, it gets into the furnaces of the cell where you're doing your electron transport. Mitochondrial respiratory efficiency, an index of the ability of the mitochondria to generate energy, was better in the CoQ patients. Troponin release, when the heart is under strain from a heart attack or unstable angina or open heart surgery, the cell membranes can rupture as they die and they leak troponin. So if we see a high troponin level in your blood, that's a bad sign. It means the cells are dying off. And it was a lot higher in the placebo group. They looked at the ability of the heart cells, the rate at which they would recover, their squeezing ability. It was better in CoQ. The length of stay in the ICU was shaved from 1.7 to 1.4 days. Length of stay in the hospital was shaved by a full day. Coenzyme Q is not expensive. It improves your outcome, and it gets you out of the hospital a day earlier. You'd think that the hospitals would want to give you coenzyme Q. They get you out a day earlier, they're going to make a lot more money. We want you to be on coenzyme Q. We're not too concerned about how many days you spend in the hospital, but we like this idea of you coming through surgery with a better ejection fraction, not needing balloon pump and dialysis and not dying. So we'll recommend coenzyme Q. Let's look at the effect of CoQ on oxidative stress, blood pressure, and insulin insensitivity in people with unstable coronary disease. 60 middle-aged patients with high blood pressure with acute coronary disease, unstable angina, small heart attack. All receive standard drug therapy, diet and lifestyle. You're going to randomize them to placebo or CoQ, 30 milligrams in the gel form, and you're going to reevaluate at 8 weeks. Vitamin E levels and vitamin C levels rise with placebo therapy as you get farther out from the unstable angina. There's a lot of free radical stress, so as you have a chance to recover, your E and C levels will rise. They rise a lot more in the CoQ group. Now, we're not giving you E and C, but we're giving you CoQ, a powerful antioxidant, to squelch the free radicals so they don't degrade your own E and C so the levels rise. Malondialdehyde is a marker of free radical stress. The bad guys are winning. it fell a lot more with CoQ. So it's a powerful antioxidant. Systolic blood pressure fell from 168 to 153. Nothing happened with placebo. Diastolic blood pressure fell with CoQ, not with placebo. Your blood sugar levels. The fasting sugar was 140 at baseline, and after 8 weeks of placebo, it fell to 129. After 8 weeks of CoQ, it was 94. Post-meal sugar also fell more. Insulin levels. If you have a high insulin level, it means you have insulin insensitivity. Basically, the mechanism of type 2 diabetes. When you're under oxidative stress from an acute coronary event, you may have some insulin resistance. Insulin levels fell minimally with placebo therapy. They fell a lot more with CoQ. And the insulin to glucose ratio, a marker of insulin insensitivity, improved more with CoQ. So we're getting a lot of metabolic benefits of coenzyme Q outside of the heart itself. Triglycerides fell, HDL went up. Coenzyme Q in kidney failure. You know, it's great for the heart. I think we've established that. The kidney is an energy-intensive organ. It's going to make a lot of ATP. Will the kidney under strain be low in CoQ? Will supplementation be evaluated as is in the heart? Kidney dysfunction is associated with free radical stress, antioxidant deficiency, endothelial dysfunction, cardiovascular disease. Antioxidants protect against kidney dysfunction due to X-ray dye. We talked about vitamin C and N-acetylcysteine. Vitamin E in the SPACE study decreases cardiac event rate. Progression of renal insufficiency, we'll talk about tissue-specific ACE inhibitors at a later talk. Will coenzyme Q help? We're going to take 21 patients with end-stage kidney disease. Their creatinine was 9 or above. That's very high. Normal's up to 1.5. They were all on dialysis or advised to begin dialysis soon. They've been stable for 4 weeks. You randomize them to get coenzyme Q in the gel form, 180 milligrams a day, or placebo. And you evaluate at baseline and at 4 weeks. And what you see, vitamin E and vitamin C levels rise with CoQ because you're squelching free radicals. Malondialdehyde, the bad marker, falls. So there's less free radical stress. BUN and creatinine are the laboratory parameters we use to gauge kidney function. The higher the BUN and creatinine, the worse your kidneys. A normal BUN is about 25. It was in the mid-80s to 90s in both groups pre-treatment. Placebo therapy didn't do much. It fell to 46 with CoQ. Creatinine fell from 11 to 5.1. It fell by 50%. Creatinine clearance is our most precise measure of kidney function. It should be 100. It was about 10% at baseline. Placebo did nothing. It tripled with CoQ. So kidney function tripled with CoQ. Urine output improved. Percent of patients requiring dialysis, basically 70% at baseline. 4 weeks of placebo therapy, 90% of them needed dialysis. 4 weeks of coenzyme Q, the requirement for dialysis fell from 73% of the patients to 36% of the patients. It works as well in the heart, in the kidney as it does in the heart. Improving outcome following heart attack. 144 heart attack patients all get standard medical therapy. Randomize them to CoQ 120 milligrams a day or placebo. Reevaluate at 28 days and at 1 year. Double-blind protocol followed, so there could be no bias. At 28 days, 28% of the patients on control therapy had recurrent angina, a bad sign. It means you're at risk for more trouble. Only 10% of those with CoQ. You can see the frequency of heart failure, low ejection fraction, arrhythmia were blunted. Non-fatal heart attack falls from 18 to 7%. Fatal heart attack falls, sudden death falls, cardiovascular death falls from 13 to 8%. Total events in the first 28 days falls by 50%, from 31 to 15%. So 16 out of 100 people who were supposed to have an adverse event were spared with coenzyme Q. What about at 1 year? 1 year out from the heart attack, 25% of those on placebo therapy had sustained another heart attack, only 14% with CoQ. Same relationship with fatal heart attack, sudden death, stroke, need for revascularization. What about side effects? Because all of our drugs can have side effects. Will coenzyme Q cause side effects? A little bit of nausea. Some people have a little bit of trouble taking in coenzyme Q. Fatigue was worse in the controls than in the coenzyme Q because your fatigue will be lessened with CoQ because your heart and your muscles and your kidney and your brain are working better. event rate at 1 year, death was 20% with placebo, 11% with coenzyme Q. Total events, 48% with placebo, 25% with coenzyme Q. So 9 out of 100 people that should have died in their first year post-heart attack were spared with coenzyme Q. If a drug did this, it would be a huge blockbuster. There'd be ads on TV. But because coenzyme Q did this, nobody wants to talk to you about it. Coenzyme Q in Parkinson's disease. I'm treating patients with Parkinson's disease with my MME machine. So I'm studying Parkinson's disease and learning all I can about it. It's a degenerative neurological disorder associated with tremor, slowness of movement, muscular rigidity, kind of you have a blank face. You have trouble with motion. It affects 1% of seniors in the United States. The problem is loss of the neurons that make dopamine, a neurotransmitter of the substantia nigra. That is the area of the brain that coordinates fine motion. There's a problem with electron transport. They're not making enough energy. You have below normal blood and platelet CoQ levels. Parkinson's disease is due to free radical damage of these neurons in the substantia nigra. And there's a lack of glutathione. That key antioxidant has been used up. There is a street drug called MPTP that becomes a free radical that can go to the substantia nigra and blow it away. That's how young people can present with Parkinson's disease as a side effect of this street drug. But with everyone else, it's due to chronic free radical stress, damage of the neurons, depletion of glutathione in the substantia nigra. Now, they have faulty electron transport. So could CoQ and electron transporter be of value here? IV glutathione helps. External counterpulsation, which improves blood supply to the brain and has an antioxidant effect, may help people with Parkinson's. CoQ supplementation increases blood platelet and brain CoQ levels. Could CoQ help in Parkinson's? Here we're going to take 80 middle-aged subjects with early Parkinson's. None are put on antioxidants. None are on anti-Parkinson's drugs. You do a baseline assessment. The UPDRS, which is the United Parkinson's Disease Registry Scale, and you randomize them to receive CoQ 300 milligrams a day, 600 milligrams, 1,200, or placebo. All get a multivitamin and vitamin E. So, and again, the E is going to work better with the CoQ. And you follow them for 16 months. It's a multi-center randomized double-blind protocol. And you find you want to have a low score. And you can see compared to placebo, the high-dose CoQ patients did well in the total score, in activities of daily living, in motor function, and in mental function. So coenzyme Q was of value in these seniors with Parkinson's disease. Why? It's an antioxidant. It helps repair and sustain cell membranes. It spares other antioxidants. It helps regenerate glutathione. There's probably other benefits, but high-dose CoQ is of value in Parkinson's. Glutathione is of value in Parkinson's. External counterpulsation appears to be helpful, and we'll be treating patients with MME, which we'll talk about in a couple weeks. So on CoQ, significant benefit in angina, heart failure, cardiomyopathy, kidney disease, statin toxicity, Parkinson's disease, hypertrophic cardiomyopathy, which we didn't talk about. Clearly improves your outcome following a heart attack or open heart surgery. Moderate benefit in BP control, and it's helpful in mitral valve prolapse, migraine, weight loss, helps you with weight loss, fatigue state, and it's good for athletic performance. How do you take CoQ? It's in powder or tablet form, but it's not well absorbed. It's fat soluble. So if you take it in tablet or powder form, take it with food or take it with some butter or something like that, it's absorbed better. Now the nutritional companies have come out with coenzyme Q in oil, a coenzyme Q gel, and it's better absorbed that way. Idebenone is a modification of coenzyme Q such that it cannot be oxidized. We're going to be switching to idebenone. The patent to manufacture coenzyme Q is held by companies in Japan. We're not allowed to make CoQ here. CoQ has been a drug in Japan. It just went over the counter. The Japanese population is buying up all the CoQ for themselves. Our prices are going up. Idebenone can be made in North America. It's probably just as good, if not better than CoQ, and it's a lot cheaper. So we're going to be, I think the benefits of CoQ you can achieve with idebenone as well. How do we generate energy in our cells? Aerobic glucose metabolism. Burning sugar in the presence of oxygen makes 36 ATP packets. In the absence of oxygen, we have to ferment the sugar. It's called anaerobic glycolysis. You only get 2 ATPs. Now that's not as good as 36 ATPs, but it's better than dying. So Mother Nature gave us this so we can generate energy to some degree in the absence of oxygen. The heart and the exercising skeletal muscles want to burn fatty acids. And we can only burn fatty acids in the presence of oxygen. In the absence of oxygen, we cannot generate energy from fatty acids. Fatty acids and oxygen, excess energy, all we need for the heart and exercising muscle. Now, how do we burn fatty acids and the glucose molecules? Well, first of all, if we take in the sugar and fat in our diet, it'll enter the cells of our heart. But that's not where they're burned. They're burned in the mitochondria, the furnace. So fatty acids can't get into the mitochondria, these long chains of carbon. So we use the carnitine shuttle. We bind carnitine to a fatty acid to make a fatty acid carnitine complex that is then shuttled into the mitochondria. The fatty acid and carnitine split. We then split the fatty acid into 2 carbon groups called acetyl groups, and we attach them to CoA, and we run them through a cycle through which we strip off the electrons and transport the electrons in the electron transport chain. CoQ works here, and we generate energy. The 6-carbon glucose molecule is split down to these 2 carbon acetyl groups. They bind to CoA to make acetyl-CoA, and we strip off the electrons in a process that requires oxygen. What happens when there's no oxygen? When oxygen levels in the heart fall, they don't have to fall to 0, but when they begin to fall, we will stop burning acetyl-CoA. Acetyl-CoA is not allowed into the energy extraction cycle. And the ratio in the mitochondria of acetyl-CoA to free CoA rises. That's a sign that we're not burning the sugar and fat properly in the presence of oxygen. That ratio, the high acetyl-CoA to free CoA ratio, shuts off all the enzymes that are used to burn sugar and fat in the presence of oxygen. And it shuts off those enzymes prematurely, even when there's still a little bit of oxygen left. This is kind of a fault of Mother Nature, but not really. Why did Mother Nature give us the ability to ferment glucose and make those 2 lousy ATPs? Well, because to keep us from dying, if we fell into the bottom of the lake and we had some trouble swimming up, rather than dying, because we can't make the 36 ATPs, we're allowed to ferment glucose and make enough ATP to keep us from dying until we could swim to the surface. Or if we're running away from a saber-toothed tiger and we go beyond our aerobic range, well, we can ferment some sugar to maybe get a few more steps and get back into our cave. This is an emergency fallback. Now, Mother Nature in her wisdom was saying, if there's not enough oxygen around, let's not waste energy activating the enzymes that would use oxygen. We're going to turn them off and turn on the fermentation enzymes. That makes sense. Well, this works well when you're running away from a saber-toothed tiger or you're swimming up from the bottom of a lake. But see, Mother Nature never planned on this situation where only one segment of our body would be oxygen deficient. She never planned on having a coronary artery block or having an artery of the brain block, okay? So the switch is set too tightly. So even though there's some oxygen left in the heart and the brain, because Mother Nature didn't plan on this, that acetyl-CoA to CoA ratio rises and we shut down prematurely. So we may die prematurely, or we'll stop exercising prematurely because there's some oxygen there, we can't use it because of a high acetyl-CoA to CoA ratio. Now, carnitine can bind acetyl groups, lowering the ratio. So you have too much acetyl-CoA, you got carnitine as a buffer, it forms acetyl-carnitine and free CoA. The acetyl-CoA to free CoA ratio falls, and you can turn on the enzymes that will use that oxygen. So you don't have enough you don't have a lot of oxygen there, you got some. If there's plenty of carnitine, you can use those last few oxygen molecules and keep making ATP so you can walk farther, you're less likely to have pain, you're less likely to die. But you got to have carnitine. What are the consequences of recurrent or severe reductions in blood and oxygen supply? High-yield fatty acid and efficient aerobic glucose metabolism ceases prematurely, even if some oxygen remains. So we start fermenting glucose, and that causes acidosis. Fatty acids aren't burned. They accumulate within the cells. Now, the carnitine tries to bind them, but you run out of carnitine. The fatty acids spill out, damage the other cells. And all of your carnitine is wasted binding up the fatty acids. So if you have a lot of carnitine, you're more likely to survive this, but this process of recurrent oxygen deficiency wastes your carnitine. So people who, just like coenzyme Q, people with strained hearts who need carnitine the most have the least amount. So how are we going to deal with this problem? We've talked about improving oxygen supply. We've talked about decreasing the demand for ATP. And we've talked now about improving the efficiency of oxygen utilization. CoQ to tune up mitochondrial ATP production. Carnitine lowers the acetyl-CoA to free-CoA ratio, promoting the preservation of high-yield aerobic energy metabolism, even in a low-oxygen environment. Carnitine delays the switch to inefficient, low-yield, oxygen-independent anaerobic metabolism, allows you to use the last few oxygen molecules better and longer. So we have studies, the same as coenzyme Q, showing benefits in coronary disease, improving outcome following heart attack, heart failure, cardiomyopathy, claudication, blood flow problems with legs. It lowers your lipoprotein, your triglycerides, good in cardiogenic shock, improves outcome following a heart attack. Just as in coenzyme Q, the more severe your cardiac impairment, the lower will be the amount of carnitine in your heart. Carnitine stores are reduced 50% in cardiomyopathy, 80% in acute alcohol or viral or toxic heart diseases. Carnitine stores are reduced in patients with chronic coronary disease. They're extremely low in muscle involved in a heart attack. They're intermediate values in the border zone. They'll be higher content in a normally oxygenated zone. Can we use carnitine then to treat angina? Logically, we should be able to. 4 studies of carnitine with atrial pacing. We put a pacemaker into your heart and we crank up the rate. So you're going to need more ATP energy. If you have a blocked artery, you don't have enough oxygen, you can't make ATP, we'll see that you'll get angina when we get your heart rate up to 125. Then we repeat the study after giving you carnitine, and you'll find you can crank the heart rate up a lot higher before the patient has angina, because you can help them handle the low oxygen environment, the increased demand for ATP. How about carnitine and treadmill performance? 900 milligrams a day of carnitine or placebo for 12 weeks in patients with stable angina. Placebo did nothing. Total exercise time increased by 12% from 11.4 to 12.8 minutes. Another minute. CoQ gives you a minute. Carnitine tends to give you a minute. Time to ST depression improved by 37%. Propionyl carnitine is used in Europe. Propionic acid is part of the, it's another cofactor in what's called the Krebs cycle that we use to generate energy. And they use it in Europe. It's a patented drug. 1,500 milligrams for 2 weeks in stable angina patients. Total work capacity increases by 17%. Exercise time by 10%. Time to ST segment depression by 14%. Carnitine and claudication. Leg cramping due to poor blood flow to the legs. Same situation as in the heart. You're not making enough ATP. Would carnitine help? 4 grams a day versus placebo for 3 weeks in claudicators. Aerobic metabolism was preserved or prolonged. Absolute walking distance improved by 75%, from 174 to 306 meters. You don't care about your biochemistry. I think it's pretty cool, but you care that you can walk twice as far on carnitine because you can still make ATP in a low oxygen environment. Carnitine and heart failure. Carnitine levels are depressed in cardiomyopathy and heart failure patients. Carnitine prevents heart muscle damage in animal models of cardiomyopathy and heart failure. Here we have patients with class 2 to 4 heart failure, treat them with placebo, which did nothing, or a carnitine 900 milligrams a day for 8 weeks. 55% improved by at least 1 functional class. Ejection fraction rose in 44%. Shortness of breath with effort was relieved in 44%. Edema resolved in a third. Overall, 66% improved. Here's another study of propionyl carnitine versus placebo in mild to moderate heart failure. Ejection fraction rose. Treadmill time improved. Symptoms improved. Carnitine in dilated cardiomyopathy, muscular dystrophy of the heart. This study was done in Italy. 70 patients with advanced dilated cardiomyopathy, class 3 to 4. They're having symptoms at rest or walking up maybe a flight of stairs. And they had pure cardiomyopathies. They didn't have alcohol toxicity, valvular disease, or blocked arteries. You're treating them all with the standard drugs, digoxin, diuretics, ACE inhibitors. None were on antiarrhythmic drugs. You randomize them to receive placebo or carnitine, 2,000 milligrams a day, in a blinded format over 3 months, then in an open format. Atrial fib flutter is a cardiac arrhythmia which we don't like to see. It'll reduce your cardiac function by 20% if you have a normal heart, by 40% if you have a weak heart, like these people. In the placebo group, 21% developed atrial fibrillation. Only 2% of those on carnitine developed atrial fibrillation. So 7 to 33 of the placebo patients developed cardioversion. Only 2 responded to medical or electrical cardioversion. 1 of the carnitine patients developed atrial flutter, and he responded to cardioversion. So it was protective against atrial arrhythmias. Mortality rate, 16% with placebo, 2% with carnitine. The patients in placebo therapy died suddenly or from congestive heart failure. Only 1 of the carnitine patients died from an arrhythmia. So symptoms improve, less likely to have arrhythmia, and you're less likely to die if you take carnitine. So we've covered a number of the studies. I'd like to focus on carnitine improving outcome following heart attack. 160 patients, consecutive patients admitted to the hospital with a heart attack. At the time of discharge, randomized them to receive for a year 4 grams a day of carnitine or placebo, otherwise the same care. Reevaluate at 1 year. Now, if you look at the carnitine versus the placebo patients 1 year later, they had lower heart rate, blood pressure, and cholesterol, angina arrhythmia less frequent. In the placebo patients, the 1-year mortality rate was 12.5%. They died of heart failure, recurrent heart attack. Only 1 of the carnitine patients died, and he had a blood clot to the leg. Wow. That's like a 1,000-fold reduction in 1-year mortality by taking carnitine. But it was done in Europeans, so it doesn't count, of course. Here's another study. You get 56 patients with an acute heart attack, and you're going to give them IV carnitine or placebo for 3 days. The number of PVCs an hour fell in the placebo patients. It fell a lot more with carnitine. Couplets, which is 2 PVCs in a row, which we don't like to see, fell a lot more with carnitine. Episodes of ventricular tachycardia, a sustained arrhythmia, which is potentially lethal, fell a lot more in carnitine. Hours with tachycardia fell a lot more. So it has an antiarrhythmic effect. Why? By preserving heart muscle and improving energy metabolism. We don't like to see a heart attack expand. If you have a significant heart attack and that area is dead, if it's mush, it'll expand out and begin to form an aneurysm. And that will kind of jerk the remaining heart segments out of sync and give you a mechanical disadvantage. It increases your risk of congestive heart failure. So will carnitine prevent infarct expansion by preserving heart cells? Here we're going to take 472 patients with heart attacks involving the front wall of the heart. You do an echo in the emergency room. You randomize them to 6 grams a day of carnitine versus placebo over a year. At the time of hospital discharge, on top of placebo, here's carnitine. Here's the end diastolic volume. Here's the end systolic volume of the heart. At the time of hospital discharge, you can already see that in placebo patients, their hearts have enlarged more than the carnitine. And then over the course of a year, they continue to enlarge a lot more than the carnitine. So the carnitine is an antiarrhythmic, and it prevents infarct expansion. And then we have another modern-day study, 101 consecutive patients with suspected heart attack. 80% had a full-thickness heart attack, all received standard medical therapy, randomized to placebo or carnitine, 2,000 milligrams a day, reevaluated at 4 weeks. And the same basic story with antioxidants and coenzyme Q. Lipid peroxides fall. LDH is an enzyme that is leaked out. The higher your LDH, the more damage. It was lower in the carnitine patients. CPK is also leaked as a marker like troponin of heart muscle damage. It was lower in the carnitine patients. The QRS score, which reflects the electrocardiographic manifestations of a heart attack, was lower with carnitine. So carnitine, just like antioxidants and coenzyme Q, appears to reduce the size of your heart attack, as evidenced by better look at EKGs, less release of the enzymes. And of course, that's fascinating to me biochemically. You want to know what effect does it have on outcome at 28 days. Recurrent angina, 36%, 12%, less heart failure, less pump dysfunction, less arrhythmia. Non-fatal recurrent heart attack falls from 14 to 8%. Cardiovascular death from 12 to 8%. Total events from 26 to 16%, similar to coenzyme Q. No one has done a study giving humans carnitine and coenzyme Q together with a heart attack. And you'd think that would be a good study to do. It just hasn't been done. There was a study in rats where they would ligate one artery and cause an experimental heart attack. And they found that with no pretreatment, it takes 60 minutes to recover, and your function's 80% of normal, and there's very low ATP. If you pretreat with coenzyme Q or carnitine, there's a better recovery. If you treat with coenzyme Q and carnitine, ATP production is not affected adversely. Carnitine, and we talked about coenzyme Q for the heart. It also helps the brain. It helps the kidney. Will carnitine do the same? Actually, most of our carnitine is made in the kidney. So if you have kidney dysfunction, you're not going to have enough carnitine elsewhere in your body. 24 patients on dialysis. One of the problems with kidney failure is your hemoglobin will fall. There's a hormone called erythropoietin that is made in the kidney that tells the bone marrow to make more red blood cells. Kidneys failing, no erythropoietin, the bone marrow doesn't work, and your hemoglobin will be low. So let's see if carnitine will help. We're going to measure the baseline hematocrit, a measure of your red count, randomize them to receive over 1 year placebo or carnitine 1.6 grams a day, and then you follow them. And here's the hematocrit in the placebo patients. Here it is in the carnitine. They were making more red cells. The hematocrit here in the placebo patients, and it's rising. So they needed fewer red cell transfusions. They needed fewer injections of erythropoietin, saving a whole lot of money. So it works in the heart, and it works in the kidney. Benefits of carnitine: reduces symptoms, improves functional status in angina and claudication, decreases symptoms and increases ejection fraction and exercise time in heart failure. It improves the outlook in cardiogenic shock. I didn't show you that study. Improve functional status, decreases mortality following heart attack and in patients with cardiomyopathy, helps preserve the red cell mass in patients with kidney failure, reduces heart muscle damage in experimental heart attack. This likely will hold true with humans. And when my patients have heart attacks, I always give them coenzyme Q and carnitine, because I want them to get through this with a high level of ATP, because I know that ATP is the only source of energy for the heart, and if the ATP level begins to falter, one by one, critical biochemical reactions will fail. And, if we can't make ATP, we only got 10 seconds, right? And then we've got 20 seconds of phosphocreatinine. And then we can, if we have enough oxygen, we can burn sugar and fat in the mitochondria to make a lot of ATP, or failing that, we can ferment glucose. But let's say we run through all these and we run out of ATP, and we got to make it from scratch. That is a disaster. We were not designed to make ATP from scratch. De novo ATP synthesis is a slow and metabolically expensive process. It takes 9 ATPs to regenerate a new one. That's not very good economics. And it's a slow process, and if we had to regenerate all the ATP in the heart, it would take us 100 days. So we don't want to have to make ATP from scratch. And we typically don't need to, because ATP is a renewable energy source. When oxygen, calories, and cofactors are available, we have ATP. We split off a phosphorus group to make ADP, adenosine diphosphate, and then we burn some sugar or fat in the presence of oxygen. We harness that energy and use that to tack the third phosphate group back onto ADP to make more ATP. And we're going to recycle each of our ATPs, I think, 70,000 times a day. That is if we have caloric fuel and oxygen. When oxygen is not available, such as in heart disease or running from Marathon to Sparta or running away from a saber-toothed tiger, Well, we split the ATP to get our work done. We have ADP and phosphate. ADP, phosphate, no energy, we can't make more ATP. Uh-oh, we got a problem here. The clock is ticking. Now we've got only 10 seconds left of ATP. What happens after that? Remember, phosphocreatinine can store a high-energy phosphoryl bond. Phosphocreatinine will give up a phosphate to ADP to make more ATP. That gives us 20 seconds. Okay, well then we're out, and we can't, there's no oxygen to make any more. So what are we going to do? There's a little bit of energy in ADP between the first and second phosphates. So two ADPs will combine to make an ATP and an AMP, adenosine monophosphate. So we get a little bit of that. Eventually, though, we're going to split off the final phosphate from adenosine monophosphate and make adenosine. Now, ATP, ADP, and AMP are charged particles. They cannot diffuse out of the cell. Adenosine does not have a charge. It doesn't have a phosphate. It will diffuse out of the cell, never to return. So if we burn our ATP down to adenosine, that substrate, that building block, will be lost from the cell forever. But let's say oxygen is resupplied. You come to the hospital with your heart attack, and we open up your artery, and we resupply you with oxygen. Or the surgeon finishes your bypass surgery and reawakens your heart. We've got plenty of oxygen. The mitochondria are still intact. We're going to burn sugar and fat. The problem is we don't have any ADP to rephosphorylate. Recovery of oxygenation, recovery of oxidative phosphorylation, not coupled with ADP rephosphorylation to ATP, gives you nothing. And this explains what's called myocardial stunning. Ischemic stress depletes ATP and the total adenine nucleotide pool. We go from ATP to ADP, ADP to AMP, AMP goes to adenosine or these other catabolites that leave the cell never to return. So each time you have an episode of chest pain, you are going to lose a certain percentage of your adenine nucleotide pool and it's gone forever. Well then how come you don't die after so many episodes of angina? How do you eventually recover? If we're losing the adenine nucleotide pool, Mother Nature must have given us a way of regenerating it, and she has. And we'll talk about that. This is the amount of ATP in your cell as a function of hours of oxygen deprivation. This could be a myocardial cell in a petri dish, an animal heart subjected to global hypoxia, or a segment of your heart supplied by a blocked artery. Over time, the ATP content falls off. Early on, the ADP rises because you can't rephosphorylate it. Then two ADPs combine to make an ATP and AMP, so it falls. AMP rises and falls. In the inset, you see the percentage of the adenine nucleotide pool, your building blocks, that is burned down to adenosine to be lost forever. Here, we're going to see this is oxygen deprivation, and at 1 hour, we reopen the artery. We resupply oxygen. It takes a while to get your ATP level back to baseline. Your new steady state's going to be below your healthy baseline. The difference is the percentage of the adenine nucleotide pool that was lost, never to return. The longer you go without oxygen, the greater the percentage of the adenine nucleotide building blocks that are lost, the more difficult it will be to regenerate your ATP, the lower will be your new steady state. These cells may not be dead, but they're not functioning well because they can't make ATP because they ran out of the adenine nucleotide building blocks. So what can we do about this? Well, we can generate ATP anew. This is called the de novo synthetic pathway. The heart was not designed to make ATP from scratch. We weren't designed to have heart disease. Mother Nature didn't anticipate it. So this pathway is not highly expressed in the heart. You start with ribose, a 5-carbon sugar. It's not present in our diet, so we have to convert glucose, a 6-carbon sugar, into ribose. That takes energy. So we get this ribose, we tack on 2 phosphate groups, and then we have to build this adenine ring step by step. This is a very, very, very slow process. To regenerate all the ATP in the heart from scratch would take 100 days. And it takes 9 ATPs to make a new building block. And if you're in the ICU suffering, you don't have any extra energy to spare. So this de novo synthetic pathway doesn't work very well for the patient in crisis. Mother Nature, though, gave us a break. If we could get ribose into the cell, and if you take ribose orally or IV, we can get it into the heart cells very quickly. The ribose will bind to these phosphate groups that are hanging around, and you can bind some of these catabolites and make AMP. So the minute you're burning the ADP down to adenosine, you can rapidly recycle it if you get ribose in the cell. So the minute the oxygen is resupplied and you get good oxidative phosphorylation, you can couple that with useful ATP regeneration. Okay? So if we open up the artery and resupply you with oxygen, your heart will not be able to use that oxygen to make ATP energy because you burned off the building blocks. If we give you ribose, you can regenerate your building blocks just like that. So the minute we improve your oxygen supply, you will respond by making ATP and your heart function will return to normal rapidly. This will block stunning. If you take an animal, let's say you take a dog, and you put them on cardiopulmonary bypass, so the heart is excised from the rest of the circulation, the rest of the organs are being perfused artificially, and you shut off the oxygen supply to that heart for 20 minutes. That's not long enough to kill the cells, but during that 20 minutes of oxygen deprivation, all the ATP, or a lot of it's going to be burned down to adenosine, lost forever. Okay? So you've depleted the adenine nucleotide pool of the building blocks. Now you reoxygenate the heart after 20 minutes. Okay? You can generate, you're supposed to be able to generate energy from sugar and fat. You don't have an adenine nucleotide pool, so you can see you're still not making ATP at 4 hours. Then if you take another group of animals and you put ribose, you give them IV ribose so they can rapidly recycle their adenine nucleotides, you reoxygenate them, they're making ATP. And this will correlate with a more rapid recovery of heart pumping function and diastolic dysfunction following this experimental heart attack in animals. Well, that's kind of interesting, but what about in humans? Think about on-pump open heart surgery. Many of you have probably had open heart surgery. During open heart surgery, your heart is excluded from the rest of the circulation, and your brain and your kidney, the rest of your body is perfused with the bubble pump oxygenator. Now the surgeons can't operate on a beating heart. So your heart is arrested, so it's still, and it's getting no oxygen. The arteries serving the heart are clamped. Now when this occurs, the heart cells cannot regenerate their ATP, and they're going to burn it all down to ADP, AMP, adenosine, and it's going to be lost. Why doesn't the heart die then during open heart surgery? Well, because it's arrested, it doesn't need as much ATP and oxygen, and they put it on ice. They freeze it. So they kind of put your heart in suspended animation. That's why the heart doesn't die. Now, if the surgery goes too long, like 8 hours, some of the heart muscle will die. That's why the surgeons are always in a hurry. They do their work and they get out of there, because the longer the surgery goes on, the greater percentage of the adenine nucleotide pool that will be lost from the heart. Okay, well, they completed their surgery. They've done their best to protect the heart, keep the adenine nucleotide pool from being depleted, but still it is. Okay, they take you off the pump. They restart your heart. They warm up the heart. They restart it. They open up these bypass grafts, and this is great. Your problem was not enough oxygenated blood. Now you've got a brand new blood supply, all the oxygen you want. Your mitochondria are going to take that oxygen and burn sugar and fat and generate energy, and man, is your heart going to work well. But it's not going to work well because you don't have any adenine nucleotides to rephosphorylate. So following open heart surgery, even successful open heart surgery, you will struggle. You will be in congestive heart failure all the time. You will need diuretics to mobilize fluid. You may need artificial support. You'll need that artificial support until your heart can generate the adenine nucleotide pool again. And it does that's very, very slowly, so you'll spend a few days in the ICU. What if you give patients ribose? Here, took a bunch of patients with bad pumps scheduled for valve replacement or bypass. At the beginning of surgery, when they cross-cramp the aorta and begin to cut off the oxygen supply of the heart. One group got dextrose as a placebo. The other group got ribose, 70 grams a day. Then they all have open heart surgery. A week after the open heart, you repeat their nuclear scan of heart pump function to look at their ejection fraction. You'd think a week after the surgery, your ejection fraction ought to be a lot higher. But 80% of the patients in the control group, their ejection fraction was still 15% below baseline. They certainly had not recovered. Only 20% of those on ribose still had pump dysfunction. They recovered pump function more rapidly because they were able to use that oxygen and make more ATP because you would regenerate their adenine nucleotide pool. So if everybody who undergoes open heart gets ribose, they would do a lot better. What about in everyday coronary disease? Here, let's look at ribose and exercise-induced ischemia. 20 men with stable but severe coronary disease, they all had abnormal stress tests with angina at about 9 minutes. You do a maximal stress EKG on day 1, you do another stress EKG on day 2. Why do you do the stress test 2 days in a row? To create ischemia, and you're going to burn off some of their adenine nucleotide pool. Why do you guys sometimes feel rotten for a week after a stress test? Because when I pushed you like that, I burned off your adenine nucleotide pool. It takes you a week to make more. So they burned down their adenine nucleotide pool, randomized them to get 3 days of ribose, 15 grams 4 times a day, or a dextrose placebo. Repeat the stress EKG on day 5. See who's going to do better. Time to moderate angina improved by 25 seconds with placebo, and that was not statistically significant. It improved more, 43% with ribose, and that was statistically significant. It's not overly impressive, but time to ST segment depression, a more objective marker of when ATP is deficient, did not change with placebo. It increased by our familiar minute with ribose. CoQ gives you a minute, ribose gives you a minute, carnitine gives you a minute. So that would translate to better physical functioning in the coronary patient if they take ribose. Ribose and heart failure. 15 patients with advanced heart failure on the basis of multiple myocardial infarctions from coronary disease. Average ejection fraction is 47%. Randomized to receive over 3 weeks ribose, 15 grams a day, or dextrose placebo, and then you reevaluate. Looking at echo measures of diastolic function, similar to the statin study, the E-wave deceleration time, atrial contribution, and left ventricular filling improved with ribose, but not with placebo. Left atrial volume, the atria primes the left ventricle, the pump. The left atria got smaller. Why did the left atrium get smaller? Because the left atrial pressure fell. Why did the left atrial pressure fall? The pressure within the left ventricle fell. Why did the pressure in the left ventricle fall? Because the left ventricle became more elastic. It relaxed better because it had more ATP. And you need ATP for your heart to relax. So your heart's going to feel better, and then you would predict those patients would feel better, and they did. Quality of life, physical functioning score improved with ribose, but not with placebo. And you could extrapolate this to all causes of congestive heart failure, similar biology. So what are the other documented benefits of ribose? It accelerates the reconstitution of muscle ATP following exercise, enhances strength and endurance gain with weight training, reduce free radical stress with anaerobic exercise, improve detection of ischemic myocardium. There's a benefit in fibromyalgia. Fibromyalgia is small vessel ischemia to the muscles, not enough ATP. Bank platelets are better preserved, and there's a bunch of predicted benefits from ribose. These studies haven't been done yet, but when they're done, they'll show what I think they'll show. Better outcome after heart attack, better outcome after bypass, etc. Whenever post-ischemic ATP deficiency is the culprit, whenever there's not enough ATP being made because of lack of oxygen, or if you push yourself beyond your aerobic threshold, and you have to then ferment glucose to make lactic acid. If you push yourself farther than Mother Nature intended wise people to push yourselves, you will suffer from ATP deficiency. I will give you an example of someone in a severely ATP deficient state. This is me at the 26-mile mark of the Cincinnati Flying Pig Marathon. I was really hurting. I wasn't making enough ATP. But actually what I did, I sipped ribose throughout the race in my water because I knew that would help me reconstitute my ATP and it allowed me to finish the marathon. So I can give all the credit to ribose. I worked pretty hard too, but it makes a nice story, doesn't it? Taurine. 62 patients with advanced heart failure on standard drug therapy, randomized them to taurine 2 grams 3 times a day or placebo, and placebo had no effect on symptoms, whereas shortness of breath, palpitations, crackle, heart size did improve with taurine. So taurine is helpful in heart failure. New York Heart Association functional class improved in 28% on taurine, only 10% on placebo. Physician assessment also showed that adding taurine in helped. Why should taurine work? It's the most abundant free amino acid in the heart. It is concentrated in the heart muscle from plasma at a ratio of 200 to 1. It has a positive inotropic effect. It helps the heart squeeze better. It enhances the positive inotropic effect of the drug digitalis, and it protects the heart from digitalis toxicity. It's a digitalis buffer. It protects the heart when there's not enough calcium, but it also protects the heart when there's too much calcium. It's a calcium buffer. It's involved in magnesium homeostasis. If you don't have enough taurine, you can't hold on to your magnesium. You got a lot of taurine, you'll hold on to your magnesium. It has a beneficial effect on endothelial function. It activates nitric oxide synthase, which we'll talk about. Taurine levels rise in the heart under strain, but just like coenzyme Q and carnitine and the adenine nucleotide pool, it's lowered in the oxygen-deprived heart. Let's look at taurine plus CoQ in post-MI outcome. 51 coronary care patients with suspected heart attack all received standard therapy, randomized them to taurine 6 grams a day and CoQ 120 milligrams a day or placebo. Follow them for 28 days. And basically it's the same story as in our prior, in the coenzyme Q and the carnitine. Malondialdehyde, a marker of free radical stress, falls. E and C are spared. CPK, there's less CPK leak, the QRS looks better, so it looks like they're having smaller heart attacks. Complication and event rate at 28 days, again, there's fewer complications and events at 28 days. Total complications, 81% with placebo, 24% with CoQ and carnitine. Death and repeat heart attack falls from 31 to 12%. So taurine's a big winner. Arginine, we're going to spend 2 sessions on arginine endothelial function. I'll just summarize here. Arginine improves or restores endothelial function. It will neutralize any risk factor that wants to damage the endothelium. It is the universal antidote to anything that causes endothelial dysfunction. In coronary patients, symptoms improve. In heart failure patients, they improve. Their ejection fraction rises. Claudicators do better. In experimental atherosclerosis, it protects against plaque buildup, does a better job than statins. Policosanol is a sugarcane extract. It is a primary therapy in Cuba because it's very, very inexpensive. And policosanol will improve lipid values, lowers blood pressure, blocks platelet aggregation, has an antioxidant effect, blunts abnormal smooth muscle proliferation, protects the endothelium. And that's a different lecture on the use of policosanol in prevention. We're talking about the use of policosanol in treatment of advanced cardiovascular disease. And I'm going to show you that it improves blood flow parameters in patients with cerebral vascular disease, increases walking parameters and claudicators, improves nuclear stress studies in coronary patients, decreases event rate in asymptomatic patients, decreases event rate in patients with known cardiovascular disease. Here let's look at policosanol in people with plugged blood vessels to their brain, people with cerebral vascular disease. 22 subjects with abnormal ultrasound studies. You do the baseline assessment, put them on a low-fat diet, randomize them to policosanol 5 milligrams twice a day or matching placebo, reevaluate in 1 year, and it was a double-blinded protocol. Now, effect on lipids, placebo therapy didn't do much. Their triglycerides rose by 31%. They rose on policosanol, but not as much. Cholesterol and LDL fell. HDL went up on policosanol, desirable effects. Carotid arteries. 46% of the patients demonstrated an improvement, a regression of disease in their carotid arteries. Only 18% of those on placebo. 36% of those on placebo showed progression in one artery, only 9% on Policosanol. Those are the carotid arteries serving the front of the heart, same situation, the vertebral arteries serving the back of the heart, or a composite. So in placebo, there was more disease progression. In the Policosanol group, there was a net lessening in the amount of plaque. Certainly a good idea. Policosanol intermittent claudication, poor blood flow to the legs. 50 subjects with stable claudication. Their ankle brachial ratio was 0.5 to 0.9. 1 is normal. If it's 0.5, that means blood flow to the leg is 50% of normal. We want to make the ankle brachial ratio go up. You put them on an exercise program, you ask them to stop smoking, put them on a standard diet, you take your baseline parameters, randomize to Policosanol 10 milligrams twice a day or placebo twice a day, and what you find, how your initial claudication distance, how far you can walk before your legs start to hurt. Placebo didn't do a whole lot, but it doubled, it tripled with Policosanol. Absolute walking distance, how far you could go before you had to stop due to pain. Not much happened with placebo. They could walk a lot farther with Policosanol. Ankle brachial ratio did not change with placebo. It improved slightly with Policosanol because you're opening up arteries. Subjective improvement in leg pain, 70% of the patients on Policosanol felt better, only 10% of those on placebo. So it sure works well, but we have to ask, is it safe? Many of the drugs that we give you have benefits, but then they have side effects. We have to ask this about nutritional therapies. Let's look at safety and tolerability. In the placebo group, 41% had to quit the study, 14% for administrative reasons, they were leaving the area, but 28% stopped due to an adverse event. 40% of the subjects had some sort of adverse event, 4 mild, 10 severe. In the placebo group, there were 2 deaths, 2 transient ischemic attacks, 2 heart attacks, 1 unstable angina, 1 stroke, 1 surgery, 1 uncontrolled hypertension. And that's the natural history of these people. They're not healthy people on placebo therapy. A certain percentage are going to have events. We want to make sure that the Policosanol group doesn't have more events than the placebo, of course, to make sure it's not dangerous. So let's see what happened there. 15% withdrew from the study, all for administrative reasons. 11% reported a total of 4 adverse events. 2 had excess stomach acid, 1 had trouble falling asleep, 1 was nervous. No heart attacks, no strokes, no deaths. So obviously, there's not a safety issue there. It improves blood flow to the legs and resolves those symptoms, but because it's improving blood flow in every artery in the body, you're going to get a better outcome. Policosanol and coronary disease, 45 coronary patients, all with ischemic abnormal stress perfusion studies. A 4-week run-in period due to the baseline studies, randomized to receive over 20 months, Policosanol 5 milligrams twice a day, Policosanol and aspirin twice a day, or placebo and aspirin twice a day, reevaluate over 20 months. Now, we're going to compare your stress thallium baseline to 20 months. In placebo and aspirin, 64% worsened. Policosanol, 25% worsened. Policosanol and aspirin, 27% worsened. Only 7% of those on placebo and aspirin improved their stress thallium, made it look better, but 1/3 of those on Policosanol improved, 46% on Policosanol and aspirin. Treadmill time didn't change with aspirin alone. It improved from 8.4 to 10 minutes with Policosanol. It improved even further from 7.8 to 10.2 with Policosanol and aspirin. ST segment depression on the exercise EKG progressed over 20 months with aspirin alone, not with Policosanol or Policosanol and aspirin. Ejection fraction, or the lipids, with placebo and aspirin, the LDL and the cholesterol went up. In both Policosanol groups it fell. That makes sense. Ejection fraction did not change significantly with aspirin therapy, from 54 to 56%. With Policosanol, it rose from 55 to 60%. Policosanol and aspirin, 53% to 61%. Policosanol is pretty good stuff. Aspirin has benefits. We can take both and get the best effects. Angina frequency fell significantly in both Policosanol and aspirin. Functional class improved only in those with Policosanol and aspirin. Now, over the 2 years before the patients were enrolled in the study, basically 90% of them had sustained an event. They had cardiovascular disease. Over the 20 months of the study, 29% of those on aspirin had an event, 1 cardiovascular death, 2 unstable angina, 1 developed heart failure. With Policosanol alone, 8% had an event, 1 non-fatal heart attack. Policosanol and aspirin, no events. So we can take the best of nutritional medicine, we can listen to what the drug medicine people tell us, we put them together, we get what we want, no events. So with Policosanol, benefits with lipid control and in treating active cardiovascular disease, improves blood flow parameters in patients with cerebral vascular disease, increases walking parameters in claudicators, improves stress thallium findings in coronary patients, decreases future event rate in asymptomatic subjects, decreases event rate in patients with known cardiovascular disease. The common goal of all physicians involved in the care of the patient with cardiovascular disease is to increase the content of ATP in the heart muscle and to improve the patient's ability to regenerate their own ATP. Because if the ATP level falls, one by one, important chemical reactions will fall off. We can deal with this problem by decreasing the demand for ATP. We can mechanically improve the oxygen supply. But what we've talked about tonight is improving or restoring efficient mitochondrial function, accelerating reconstitution of the adenine nucleotide pool so you can get more miles per gallon, more ATP energy particles per oxygen molecule from the oxygen available. And this bioenergetic support can be added on to any drug or surgical therapy, and it's going to have an additive benefit on outcome. And we have some recommendations that I've taken from the literature, the studies that I presented to you. These are the doses used in those studies for angina, heart failure, post-bypass outcome, renal insufficiency, claudication, hypertension, cardiac fatigue, and arrhythmia, and improving outcome following heart attack and decreasing your likelihood of dying after a heart attack. And that's all I have to say on this subject. Thank you very much for your attention.